Hello students, welcome you all to this video. In this video, I'm going to talk about the active management of the third stage of labor. I'm Ruth Kezia, working as a tutor in Tripoli College of Nursing. The objectives of this video, we are going to talk about the definition of the third stage of labor, mechanism of placental separation, science of placental separation, active management of the third stage of labor, examination of the placenta, membranes, and the umbilical cord. Okay, why AMTS? Okay, so the active management of the third stage of labor is shortly called as AMTSL. Why we have to study about this? Because the studies have shown that AMTSL prevents up to 60% of postpartum hemorrhage, that is PPH, and additionally AMTSL have shown to decrease the incidence of PPH, and it's shown to decreases the length of the third stage of labor, and it decreases the duration taken for the third stage of labor, because whoever admits this, follows this AMTSL during third stage of labor, it's not going to last more than 30 minutes. Next, it reduces the need for blood transfusion, and it decreases the need for use of this uterotonic drugs to manage PPH. Okay, the definition of third stage of labor, it is the time from the birth of the baby to the expulsion of the placenta and its membrane. It is the most crucial stage of labor. Placenta generally delivers within 5 to 20 minutes in both primi and multigravida. With active management, it is reduced to 5 minutes. The events in the third stage of labor are placental separation, descent to lower segment, expulsion with membranes. Okay, when the baby is born, the third stage will begin. The contractions is weaker in this time will start up again. These will make the placenta gradually peel away from the uterus, and the mother may get the urge to push again. The placenta with the membranes of the empty bag of waters attached will drop to the bottom of the uterus out through the vagina. Signs of placental separation. So these are the 4 signs of placental separation: gush of blood from vagina, change in size, shape and consistency of uterus, umbilical cord length increases, and mother has the urge to push. These are the signs of placental separation. Mechanism of placental separation. There are 2 mechanisms, that is Duncan mechanism and Sculls mechanism. As you see in the picture, the Duncan mechanism, here the placenta separates from one margin to the other margin, but in Sculls mechanism the separation starts at the center. Okay, the same is explained again in this picture as you see it here. The placental separation in figure A, it starts in the center, that is at the fundus of the uterus. Here in B, it starts from one margin and ends to the other. Okay, so the central separation is called Sculls method. The detachment starts from the center, uterine sinuses are opened, retroplacental collection of blood occurs, resulting in further separation. Marginal or Matthew Duncan method. Here the separation starts at the margin, more area gets separated with the progressive uterine contractions. This occurs more frequently. 2 methods of third stage management. So till now we have seen about the science and the mechanism of placental separation. Now we are going to see about the management of the third stage of labor. There are 2 methods. In that, the first method is the physiological or expectant management. Here what we do not administer any uterotonic drug. The placenta is delivered by gravity and the maternal effort, and the cord is clamped after the delivery of the placenta. The second method is the active management, that is AMTSL. Here oxytocic drug or the uterotonic drug is given. Cord is clamped, placenta delivered by controlled cord traction with the counter traction on the fundus, fundal massage. This speeds up the third stage and you won't have to do any pushing. Okay, so the components of the AMTSL active managements are administration of uterotonic drug, controlled cord traction and uterine massage. Okay, this is the flow chart in the third stage of management of the third stage of labor. First, it starts with the delivery of the baby, and immediately after delivery, you're going to administer injection oxytocin 10 units IM within 1 minute. And then after cord is clamped and cut and ligated. The placenta, after cutting the cord and handing over the baby to the resuscitation staff, you'll be having the cord lying outside of the perineum, and the placenta will be inside the uterus. So that time you will have to give the placenta controlled contraction, okay, and with the uterine massage. If this attempt failed, then you will have to wait for 10 minutes and repeat the procedure. See, the same is explained here in the picture. Here, give picture 1. Give oxytocin within 1 minute of childbirth. Number 2, deliver the placenta by controlled contraction on the umbilical cord and counter pressure to the uterus. So one hand should hold the cord and give gentle traction for the placenta to deliver, and the other hand should be simultaneously doing the massage on the fundus of the uterus. Massage the uterus through the abdomen. So once the placenta is delivered along with the membranes, the third one explaining the massage the uterus through the abdomen after delivery of the placenta, and during the recovery palpate the uterus through the abdomen every 15 minutes for 2 hours to make sure it is firm, and monitor the amount of vaginal bleeding. So after the delivery of the placenta, it is important to always check for the uterus consistency, whether it is firm and contracted. Okay, the consistency of the uterus should be like a cricket ball, so it should be that much hard, and it is very important to note the contraction of the uterus every 15 minutes for about for the next 2 hours. So in order to early identification of the PPH, this should be done. Okay, the next key point you will have to remember is, before starting the management of the third stage of labor, rule out the presence of another baby by palpating the abdomen and trying to feel for the fetal parts. So there may be a case like unidentified twins. So in order to avoid that, you will have to palpate before administration of the uterotonic drug, or before carrying out the the uterine massage, and carrying out the separation of the placenta and the membranes. So always look for the unidentified twins. Next is the uterotonic drug. So the 3 components we are going to see in detail. So first is the uterotonic drug. Enhance the contraction of the uterine muscles. What it does, it will contract the uterine muscle. It helps in the prevention of PPH, that is postpartum hemorrhage. Injection oxytocin is the drug of choice. Tablet misoprostol is also to be used. It should be ideally stored in a refrigerator, kept at a temperature of 4 to 6 degree centigrade, but not frozen. Injection oxytocin and should be given at the anterior shoulder 5 to 10 units IM, or give a tablet misoprostol 600 microgram orally. Inform the woman that shivering and gastrointestinal disturbances are common side effects. So you will have to know that misoprostol and oxytocin can cause shivering and gastrointestinal disturbances. So this is about uterotonic drug. Next is the CCT, controlled contraction. It is a technique that assists in the expulsion of the placenta to reduce the chances of retained placenta and subsequent bleeding, that is PPH. Clamp the maternal end of the umbilical cord close to the perineum with a pair of artery forceps. Hold the clamped end of the cord with one hand. Place the other hand on the mother's abdomen to feel the uterine contractions. Maintain slight tension on the cord. This is how the CCT must be performed. The uterus contracts as will be evidenced by the uterus becoming hard and globular. Gently pull downwards on the cord to deliver the placenta. Apply counter traction on the uterine fundus. If placenta does not descend within 40 to 60 seconds of CCT, do not continue to pull on the cord. Wait for the uterus to contract strongly again and repeat. Do not exert excessive contraction of the cord while performing CCT. Do not repeat the maneuver more than once. So as you see in the picture, this is the procedure to do a controlled contraction. One hand is holding the artery forceps with the clamped umbilical cord, and the other hand is giving the gentle massage on the uterine fundus. Okay. So this is how we have to deliver the placenta. When the placenta comes out, you have to hold the placenta with both the hands to in order to prevent the tearing of the placenta. As the placenta delivers, hold it with both hands to prevent tear. Normally, the placenta delivers within 5 minutes of the birth of the baby if AMTSL is done actively. If pulled, the three membranes can tear off and get retained in the uterus. So, if the membranes tear, use your fingers or a pair. If the membranes tear, you should use your finger to take away the membranes or use a pair of sponge holding forceps to remove the membranes. So as you see in the picture, this is the membranes, complete membranes attached to the placenta. Okay, in the dummy also the white thing is the membranes attached to the placenta. Ensure the placenta is delivered completely with all the membranes. Retained placental fragments or pieces of membranes will cause PPH. These can be suspected if a portion of maternal surface of the placenta is missing. If the placenta is not delivered after 30 minutes of injection of oxytocin or tablet misoprostol, you should refer the woman to the referral unit. Inform on the information on the with the referral slip you have to refer the woman. So next is after the delivery of the placenta along with the membranes, you will have to do the examination of the placenta and membranes and the umbilical cord. So how to examine the placenta? First is the maternal surface. The placenta has got two surfaces. First is the maternal surface and next is the fetal surface. Maternal surface, hold the placenta in the palm of the hands, keeping the palms flat and the maternal surface facing you. Look for the following. So maternal surface, what is the structure we see is the cotyledons. Okay. All the lobules should be present. There will be at least 15 to 20 lobules in the maternal surface of the placenta, and these lobules or cotyledons should be fit together. There should not be any irregularities in the margins. If any lobes are missing or lobes do not fit together, suspect that some placental fragments may have been left behind in the uterus. So as you see in the first picture, the surface is the fetal surface, the upper margin. The second picture shows the cotyledons, which is the maternal surface. So this surface only attached to the deciduum of the uterus. Hold the umbilical cord to one hand and let the placenta and membranes hang down like an inverted umbrella. So if you hold the umbilical cord with one hand and allow the placenta to fall down, then the placenta along with the membranes will hang down like an inverted umbrella. So why you should do this? In order to examine the completeness of the membranes. You should also look whether the membranes are missing or not. Approximation of the membrane should be looked. The umbilical vessels will be seen passing from the cord and gradually fading into the edge of the placenta. Look for free-ending vessels and holes which may indicate that a lobule has been left behind in the uterus. Look for the insertion of the cord, particularly the velamentous insertion. Okay, normally the cord is inserted at the center of the placenta. But if the insertion, as you see in the picture number 2, if the insertion is at the margin of the placenta, then it is called as a velamentous. So, sorry, the margin of the placenta means it is called the battledore placenta. If the umbilical cord is attached to the membranes, okay, then it is called as a velamentous cord insertion. Okay, so we saw the cotyledons, okay, the maternal surface, the fetal surface. Now we are going to see the how to examine the membranes. So there are two layers in the membranes, chorion and amnion. Both layers can be seen at the edge of the hole where the membranes rupture and the fetus comes out. If the membranes are ragged, place them together and make sure that they are complete. So as you see in picture A, that is a membrane. In picture B, they have separated the amnion and the chorion. Okay, in the picture C is completely the amnion, the inner layer. Okay, so that is about the membranes. Now we are going to see about the cord. The cord, normally the length of the cord is 50 centimeters. Okay, so and there will be at least two arteries and one vein. in the umbilical cord normally. So there will be 3 blood vessels as you see in the picture. The umbilical vein will be the larger blood vessel and the 2 umbilical arteries will be small. And that should be checked for all the babies, presence of 2 umbilical artery and 1 umbilical vein. If there is single umbilical arteries, then you will have to suspect for any congenital malformation in the baby. So this is how you check a cord. The normal length of the cord is, as I said, it is 50 centimeter, and there should be presence of Wharton's jelly around the cord, okay, umbilical cord, which helps in prevention of any formation of the knots. And if the cord is less than 20 centimeters, it is called a short cord, and if it is more than 50 centimeters, it is called a long cord. Okay, so that you should keep in mind. So this is how you have to check the umbilical cord. Next is measuring the fundal height during the 3rd stage of labor. At the end of the 3rd stage of labor, following the expulsion of the placenta, the fundus is about 4 centimeter below the umbilicus. So we will have to measure the length of the fundus after the expulsion of the placenta. Next is uterine massage. You will have to do the uterine massage even after the placenta is expelled because this will prevent PPH. Place the cupped form of your hand on the uterine fundus and feel for the state of contraction. Massage the uterine fundus in a circular motion. A well contracted uterus feels like a hard cricket ball. Place your finger behind the fundus and push down in one swift action to expel the clots and collect the blood in a container. Estimate and record the amount of blood loss. So the amount of blood loss is it also should be measured, and the intake output chart should be maintained. Okay. And next, what we have to do is you have to settle the woman, help the mother to breastfeed. So immediately after delivery of the placenta and the umbilical cord and the blood vessels, okay, membranes, you will have to put a clean sheet under the mother's abdomen and wipe the perineum. If the episiotomy is done, suture the episiotomy, then feel for the contracted uterus and check the amount of bleeding and apply a good perineal pad. Make the mother to lie down completely rest and help the woman for the breastfeeding. Okay, if the woman cannot breastfeed, encourage manual nipple stimulation. Check the uterus and vaginal bleeding at least every 15 minutes for the first 2 hours. Massaging as and when necessary to keep it hard, and make sure the uterus does not become soft or relaxed after massage. If the uterus remains soft and flabby, the woman may be suffering from atonic PPH. So if the uterus is relaxed even after all the measures, this condition is called atonic PPH. This cannot be managed in a peripheral center. You will have to always refer the woman to the referral unit. So this is about the active management of the 3rd stage of labor. We saw the definition of the active management of the 3rd stage of labor. What is the time duration? Why we need to do AMTSL, and what are the signs of placental separation, mechanism of placental separation, management of AMTSL, that is physiologic management and active management. And the components in the active management are administration of uterotronic drug and controlled contraction along with uterine massage. And after that, we saw about the examination of the placenta, membranes and the umbilical cord. So I hope you gained some knowledge about AMTSL. Thank you. We'll see you in the next video.